Hello, everyone. Thank you very much for the introduction and invitation, Olga. I'm really glad and happy to be back here with you. My name is Charlotte Lilien. I'm research physiotherapist at the MD UK Oxford Neuromuscular Center. And I've been involved in spinal muscular atrophy since quite many years. So I will have actually today two different presentations. The first one will really focus on the concept, what is actually the role of physiotherapy in SMA. And the second one will really focus on specific clinical cases. So there also I would like to thank Olga because she was a great support to provide some very nice videos of patients. So I would say, let's start. So I hope everyone can see my screen.
Yes, we can see it very well. Thank you.
Okay, perfect. So you see it, great. So yes, first of all, these are just my disclosures. And I wanted to start first by saying, I mean, you all know that we have a switch off in the classification, right? We are less talking about SMA type 1, 2, 3, and 4. But with all these new disease-modifying therapies, we had a huge shift of the classification, right? And we're much more talking about non-sitter, sitter, and walker. So this is something that's not new. The other thing is that although the standards of care were actually introduced in 2018, I mean, also before, but they were republished in 2018, we will also need to shift our way of thinking to provide standards of care to those patients. Yeah, because we do have different phenotypes now with those disease-modifying therapies according to baseline functional level, according to age therapy initiation. And so it's not because the patient is treated with a disease-modifying therapy that he will not need standards of care anymore. Yeah, so it's really important to keep in mind that all patients, especially those who are treated post-symptomatically, are still considered as patients with SMA. And so they will still need an adapted way of standards of care according to their needs. Yeah. So how do we provide the best standards of care as possible for patients with SMA? Well, since SMA is a multisystemic disease, we will need actually a multidisciplinary care approach. And for this, we have many different interveners. Yeah, of course, you will not always need all of them. Yeah, it's really according to the patient's phenotype, to the patient needs, to the patient's trajectory. Yeah, although the most common, are the neurologist, the orthopedist, the pulmonologist, and the physiotherapist, which is actually what I'm going to focus today. Some patients will, for example, also need an occupational therapist. Another one will maybe need a psychologist, or maybe also the parents. So you see, it's very important to keep actually a broad picture of your patient. So let's speak today about physiotherapy. Yeah? So what is the role of the physiotherapist? Well, first of all, you have it's really important on one side to be able to progress, to assess the progress of the patient. Yeah, because assess the progress of the patient will permit you to understand his disease trajectory. Yeah, and understanding his disease trajectory will permit you to orient the rehabilitation, your care plan. Yeah, and adapting the care plan will, of course, have then an impact on the disease trajectory of the patient. So you see, they are both really linked to each other, and it's really important to do both to provide the best care also for the patient. Yeah, so let's first start talking about the assessments. So for assessments, there are two different ways to assess the patient. The first one is the clinical assessments. This is really regardless of the functional states. It's going to be for all the patients the same. Yeah, so you're going to check postural asymmetries. How is his scoliosis, for example? How severe or not is maybe his thorax deformities? Yeah, you will check for contractures. What are the range of motion of the different joints of the patient? Yeah. Regarding pain, pain is a real important aspect in patients with SMA, especially for those who are severely contracted and weak. Yeah, because they are usually always in the same position. So it's really important to provide a good pain management. Yeah, and maybe adapt the positioning and braces in order to avoid any pain. Yeah. And then, of course, the communication. This is really something very, very important. And you will see, I will talk about this several times and highlight this several times during both presentations. It's not only the doctor who decides what's good for the patient, or the physiotherapist who decides what's good for the patient. No, it's actually a communication between the patient, the family, and the intervenants, the team member of the multidisciplinary care team. This is really important because together you will be able then to provide the best care for the patient. And then you have on the other side the functional assessments, and this is really according to age and functional status of the patient. And there you have really the usual suspects that we have, the functional scales that we are using since many years in the frame of clinical trials, but that we also need to use now in the frame of our care and our follow-up, because of the market approval of the different disease-modifying therapies. So, for example, we do have the CHOP intent, which is for patients which is actually for infants until 2 years of age. It's a scale that permits you to understand what are the reflexes, what are the global motor function of your patient. Then for the youngest one, you also have the HINE-2, which is a section of the broader HINE. It's the Hammersmith Infant Neurological Examination Scale. And the HINE section 2 is really focused on the motricity. So it's more about motor milestones. And then you also have the Bailey scale. And the Bailey scale, well, you have the Bailey 3, but now you also have a Bailey 4, because of course those scales are always readapted and without, etc. But what's actually quite nice with the Bailey is that it's divided into different domains. And for example, you have a domain focusing, targeting the cognitive impairment of the patient, or maybe the speech, and also the speech and language. So we have seen that it's more and more important actually to not only focus on the motricity of the patient, but also to check how is the cognitive development of the patient. And for this, for example, the Bailey can be a good tool. And then for the older patients, you have, for example, the MFM 32, which is the motor function measure scale 32. And it's a scale which is divided into 3 domains. You have standing and transverse, you have axial and proximal motor function, and then you have the distal function. And what's nice with this scale is that it permits you to assess patients who are ambulatory and non-ambulatory. So for example, patients who are currently losing ambulation, it's very interesting to use the MFM because it permits you to have a longer follow-up of the patients. The only thing is that it's not a disease, it's not an SMA specific scale. But on the other side, since we have so many different phenotypes today, it can be actually something good. Because our SMA specific scales today, like the Hammersmith or the RUM that we also have here, are really based on patients in natural history that we had 10 years ago. They are still, of course, relevant. It's not what I'm saying. It's just that it's important to sometimes think outside of the box. And so we have then, as I said, the 2 SMA specific scales. So it's the Hammersmith Functional Motor Scale Expanded, which gives you also an idea about the gross motor function of the patients. It's also for non-ambulatory and ambulatory, but it's more for stronger patients, stronger phenotypes, if you want. So I used to use actually the MFM for, let's say, weaker phenotypes. And the Hammersmith combined with the ROM, I use it for the more stronger phenotypes, because the ROM is the revised upper limb model, which provides you an idea about the upper limb function of the patient. And then at the end, we do have the 6-minute walk test, which is a very well-known scale that has been used in many, many clinical trials, not only SMA. And it's actually a test for only the ambulatory patients, because it gives you an idea of the global function of the patient while he's walking. So then we talked here about the assessments, but now let's talk about the rehabilitation. So here the idea of this presentation is to not give you a cooking recipe. I'm really sorry. I hope I don't disappoint you, but it's important to not have this kind of picture in mind, like all the non-sitters must have this, all the sitters must have this, all the patients who are walkers must have this. No, absolutely not. first thing that you need to do when you have a patient in front of you is to keep the general objectives of physiotherapy in SMA in mind. And they are, the first one, management and prevention of secondary consequences, like the contractures, the scoliosis, or the respiratory complications. This is something that is really, really important and that will really also impact the patient. Yeah. The second is to maintain and to improve the motor skills. Whenever you want to provide a care or rehabilitation plan, you always need to say, okay, my exercises need to permit to maintain what we currently have. And since my patient is treated, we might maybe be able to improve his motor skills. The last point is, of course, to provide the best independence for the patient. Yes, so and this is by trying to adapt the daily activities to his daily environment. Yeah, and for this, of course, you will need the help of the parents, because they will be the one who will be able to tell you how it is at school, how it is at home, what the patient actually needs. Yeah, and so this is, again, communication is key. Yeah. The second point, when you have the patient in front of you, so you have your objectives in mind, the second point now is are the principles. Yeah. And so the first one is you need to promote function. Yeah. Whenever you are providing exercises or rehabilitation to your patient, you don't need to be analytic. No, it makes no sense. Yeah. What you want is to provide functional exercises that will help patient in his daily life. Yeah. This is also why you will need to promote a global approach. Again, you will not focus on only one tiny muscle. No, it makes no sense. You will focus on the whole upper limb. Yeah. The third point is to maintain the patient's motivation. I mean, SMA is a lifelong disease, yes? And as I said, patients who are treated post-symptomatically are still considered as patients with SMA. Yes, of course, we will have different disease trajectories and different phenotypes and different evolutions, but they will still stay patients with SMA. Yeah, so it's really important to try to find a good balance, yeah, between too much care, not enough, yeah, and to keep them motivated by providing rehabilitation with funny activities, yeah, like for example swimming pool, or doing something nice like activity for fine motricity, doing something nice that the patient also enjoys. Yeah, otherwise if it's always a pain for the patient to do the exercises, it will not work. Yeah. Another point is to always promote patient comfort and autonomy. Yeah, what we want is to, of course, we need to assist our patients. We need to be there with them, but it's important also that they learn to be as autonomous as possible. Yeah, this is what I always do when I have patients coming to our hospital and to my consultations. Is that okay? Sometimes it takes a bit more time, but I let them, for example, taking their shirts off on their own. Yeah, I'm not saying, okay, come, I want to be it very quickly, so I will do it for you. No, it's important that the patient understands that he needs to do also things on his own and that he can do it also on his own. Yeah, in comfort, of course, you will also always need to have the adapted equipment and material for your patient. Yeah, you will need to promote education of the patient and family. If the patient and the family don't understand the aim of your rehabilitation plan, it will not work. Yeah, it's really important that they understand what you're trying to reach, and this is why it's important to have actually like a plan. Yeah, and to do it step by step. And this is why it's important to discuss this and to talk this with the parents. Yeah. SMA is a disease where you have a huge impact of the fatigability. Yeah, so it's not like the patient needs to give his maximum all the time. This is what will help. No, you need to respect the fatigability of the patient, and every patient has different level of fatigability, as myself as well. So I mean, it's really dependent to each patient. So you will need to adapt. Sometimes for one patient, it's going to be 30 repetitions of an exercise, and sometimes for patients, it might be 15. Yeah, and it's not bad. It's just that you need to adapt it according to the patient that you have in front of you. And the last point is that you really need to respect the pain and the limit also of the patient. Yeah, the rule, no pain, no gain, doesn't apply in SMA. Okay, this is something I know that we usually keep that in mind when we want to achieve something, but no, Yes, of course, we always need to go a bit out of our comfort zone, but no pain, no gain doesn't apply here. Okay, so the rehabilitation is really according to the functional status of the patient. Yeah, so as I told you, there is no cooking receipt, but still there are some specific guidelines according to each type or functional status of the patient. But the first thing that you need to keep in mind, which is the most important thing, is the conservative approach. You want to keep that what you currently have. Yeah, SMA is a progressive disease. Yeah, also the patients who are treated, we see that they will maybe improve. Yeah, for some patients they will improve, but maybe they will also then decrease or have more contractures. We don't know. Okay, it might happen. So what you need to first do is to have a conservative approach and to manage the contractures. Yeah, you need to avoid the disuse of muscle atrophy. Yeah, you will need to really focus on the respiratory care, because this is a so important point in patients with spinal muscular atrophy. Yeah, you will need to check the positioning. What is the best way? What is the best way to position the patient so that he can have a really nice social interaction? Yeah, patients who are in supine all day long, it's complicated. So it's important to find then adaptations so that the patient can really feel that he's part of our life. Yeah, that he's around the table. He can exchange with his peers, with his friends, with the family, and be really there. This is really important for everybody. Yeah. So also it's also to feel included in the society. This is really important. The second approach is the proactive approach. Yeah, since here most of patients are not treated. Yeah, I mean many patients are treated. So you will need to think also in a proactive way. Okay, we have new emerging phenotypes. Yeah, patients, for example, SMA patients considered as SMA type 1, so who are non-sitters, who are treated, might be able one day to sit independently. Yeah, so your rehabilitation will not only focus on we only need to keep what we have now. You will need to do that, but you will also need to add then some exercises and rehabilitation care program to permit the patient to go towards a sitting position. Yeah, you will need to stimulate that. Yeah. And then the last point is the complementary techniques and activities. And this is really, as the title says, these are complementary. It's a complementary approach. Okay, you will, for example, never put the hydrotherapy or the massage at first instance before the stretchings, for example. I know that here it's really dependent on each country and each guidelines, and I think it's important to be very open-minded and to understand and to listen how things are working elsewhere. Yeah, I'm learning every day. Yeah, it's just that I think that according to me, it's really important to find a good balance between what is really necessary for the patient, and for me, it's the conservative and the proactive approach, and what can we do as top on. Yeah, so what can be nice also for the patient and also benefit him. Yeah, and this is then the complementary techniques. So when you are providing a rehabilitation plan, it's really important to avoid high intensity training. Yeah, I know that sometimes it might be logic to say, okay, we do have a patient with, let's say, no muscles, yeah, and we will need to reinforce him with weights. Yeah, no. It's important to avoid this, because it will provide some mechanical stress. And the muscle will be replaced with fibrotic tissue, because you will have an atrophy and a necrosis of the muscle fibers. Okay, so it's really important. You cannot provide the same rehabilitation care to a healthy person than compared to you cannot provide the same rehabilitation plan to a patient with SMA as the one to a healthy person. Yeah, they have a total different anatomy and physiology. So just be careful of that, and always use then the submaximal intensity. Yeah, again, you need to respect the pain and the fatigue. So the next point is important that we understand our patients. Yeah, so who are they, And what do they actually expect? Yeah. So there has been a very nice study conducted by SMA Europe. Yeah. And they published that the patients, almost all 95%, or more than 95% of patients considered a stabilization to be a positive outcome from treatment, yeah, regardless of disease status, age, or geographical origin. That's true. However, when you discuss with each patient, yeah, when you discuss and really take the time to try to understand them, you will see that they will all have different expectations, yeah, and this is usually depending on their functional status, yeah. For example, when you have, for example, like this young lady here, yeah, 25 years old, SMA type 2, and so non-sitter, and she knows that she will not be able to walk one day, yeah, even if she's treated, yeah, with any kind of therapy. Yeah, it's just because of her contractures, it will not be possible. Yeah, I mean, right now, with what we have. So she don't even expect that. But what she wants is to keep her social life and to go out with friends. Yeah. And the same with this young man here. Yeah, he's journalist and he wants to keep the ability to type on his laptop. Yeah. On the other side, you will have much younger patients and also then their parents, and they really want, yeah, it would, of course, a stabilization would be great. We see this as positive outcome, but to be honest, we would be happy if they could walk one day. Yeah, because one wants to play handball with her friends and another one wants to travel around the world. Yeah, and with backpack and everything. Of course, you can still do it, but I mean, it's just different expectations, and this will also help you to orient the care plan. Yeah, you will know what you will need to target, what is important for the patient, what is not important for the patient. Yeah, because otherwise there are so many things that you can do with a patient with SMA. So it's important to understand what is important for him. Yeah. So, and this is what I said, that it's really important to provide a patient-centric approach to your patient. Yeah, and how do you obtain a patient-centric approach? Is that you need to see the patient as an individual, as a one with his own disease. Okay, it's not okay. Here we have a patient, a non-sitter. Yeah, so it's a type 1. Okay, it's as all the other type 1s. No, absolutely not. Okay, you will need to listen to your patient. You need to be able, and this is also by discussing and taking into consideration the opinions of the multidisciplinary care team. Yeah, because everyone will have discussions with the patient. And so you will be able then at the end to have a broad picture of your patient, to understand what is actually his goal. Yeah, and what does he actually want. Yeah, the same also, you need to do it with the family and then also with the community PT. Yeah, if it's a different one. For example, when I was working before joining in Oxford, I was working in Paris, and during that time, I was a lot in contact with the community physiotherapists, so the one who were providing the rehabilitation to the patient. Yeah, and so it was not, I called the community physiotherapist and I told him what to do. Absolutely not. It was more, I was more like a reference point. And I was like, look, I had this patient, it was a 6 months follow-up, and I've seen this, and this. What do you think? How could we maybe adapt the rehabilitation care plan? It's important to work together again, okay? Communication, again, communication is key. Yeah, and so this is a question that I had so many times, yeah, is parents coming to consultations and saying, look, we know we have a problem. We don't have a physiotherapist who is specialized in SMA. Yeah, so we don't go to the physiotherapist. Yeah, and so do you actually need an SMA specific physiotherapist? Absolutely not. Okay. However, what you need is to understand the objectives of your care plan, to understand your patient, and to keep the principles in mind. Yeah, and so even if you have a physiotherapist who is not specialized in SMA, we, for example, myself as a tertiary care PT, I was then able to call the community physiotherapist and then provide to him all the necessary information. Yeah, what does he need? What is actually maybe SMA? Maybe sometimes you need to explain what it is, and what could be actually the ideal care plan and rehabilitation plan for this patient. Yeah, it's really, again, to work together what will help the patient. Yeah. Spasiba. So unfortunately, with the translator, you cannot hear my great accent in Russian.
Thank you.
Thank you very much. And I will go now straight to the second presentation. Yeah, I think the questions will come at the end. Yeah, it's just, there is one phrase that I actually really like, and it's actually that you don't have to forget that we are treating a patient and not a disease. Yeah, and this goes actually not only for SMA, it goes for any kinds of patient. Yeah, but this is really important to keep in mind. So now we go to the second one. So here, the second presentation will really focus on clinical cases. And here I really want to say first, yeah, that the content of this presentation is purely educational, and it absolutely doesn't replace a face-to-face consultation. Yeah, you really need to consider the content carefully, because my reflections, advices, and comments are only based on the videos that I received, and I only had a limited medical history knowledge about the patients. Yeah, and this was really with the great support of Olga, so thank you very much again. And the second point also that I want to say is that these are really examples of different phenotypes of patients. Yeah, again, there are not two identical patients. No cooking recipe. Okay, please don't put them in boxes. Okay, and so I really would like also to thank the patients and the families for sending the videos to create today's content. So what do we remember from the first presentation is that we need to understand the individual needs of the patient, to understand the objective of the care plan, and to keep the principles in mind. Okay, so regarding the rehabilitation, as we have seen, it's according to the functional status of the patient. Yeah, so we're going to first start with non-sitter. So here we have Alexandra. Yeah, Alexandra is a non-sitter. Yeah, and she is 1 year and 9 months old, and she was never able to sit, never able to roll. She had no head control, just slight movements. So we expect a quite severe phenotype. Yeah, and although she also received disease-modifying therapy, but she also has a current physiotherapy care plan where she got AMBU therapy, breathing exercises, cough assist, gymnastic at home, massage, and stretching. So the care plan is quite good because it's quite broad, but I think that it needs to target more the current needs of Alexandra. Yeah, so let's see this together. Okay, so first of all, here we do have Alexandra. Yeah, so here we see there is a general severe hypotonia, yeah, with contractures in the hips, in the knees, but also in the ankles. And I'm not sure if you've seen it very well, but it was also in the shoulders and in the elbows, so also in the upper limbs. And here we see a huge thorax deformity, okay, with a lot of breathing difficulties. So there is a huge sign of respiratory distress. Yeah, and we also clearly see that she's on the weight. Yeah? So what are then the additional questions that you will need to ask to your patient as physiotherapist, yeah, to the parents? Is first, what is the current orthopedic management? So currently she does have a special functional chair, but she doesn't use it much. Apparently she feels unwell and cry a lot while she's sitting in this chair. Okay, and she's also producing a lot of mucus during sitting there. The standard, she's not using it currently, and she also got some splints for the lower limbs, okay, that she only wears during the day. Ventilatory support, so the respiratory aspect, very, very important. So currently, she's only using the BiPAP during nighttime. Yeah, and then the additional information again are regarding here for the dietitian. Yeah, so she has an oral intake, but several months ago she stopped to eat. Okay, she was able to swallow, but she vomits instantly. Okay, so now she does have another gastric tube, okay, which is good. But not long time ago, she had a bilateral pneumonia. And this is the problem, is that this is because of aspirations. Yeah, it's because she had the oral intake that she had an aspiration, and then which led to a pneumonia. Okay, so this is where you must be really, really careful. And actually, this nasogastric tube should have been placed a bit earlier, I think. So, and then we plan also, they also plan to have a rehabilitation like speech therapists for the restoration of the swallowing skills, which is great, which is super important. So regarding the functional assessments, yeah, because there we had the medical history, we had then the visual examinations, and now we need to perform the functional assessments. Yeah. So here we do have a patient who is less than 2 years of age and also presents a severe hypotonia. So what are the scales that we are going to use? The CHOP intent, yeah, to understand the global motor function of this patient. Yeah. We can also do the Heine, which gives an idea about the motor milestones of Alexandra. And we can also add, I would, for example, add the cognitive and speech and language domain of the Bailey. Yeah, to avoid redundancy. Yeah, you will not do the whole. I mean, I wouldn't do the whole Bailey because you already have the Heine and the CHOP intent. But I would maybe add the, as I said, the cognitive and the language domain, because this can be very interesting. Yeah. So regarding the physiotherapy care approach, what do you need to do with Alexandra? Yeah, it's first of all, you will need to manage the contractures. Yeah, you remember this conservative approach I was talking about? It's the most important part. Okay, this is to try to keep what we currently have. Okay, so you will need to do the manual stretching of her upper and lower limbs. Yeah, but also of her neck and her trunk. Yeah, it's really, really, really important. I mean, manual stretching in SMA is like brushing teeth. Yeah, it's something that you need to do every day. Yeah, and you don't need to do it for 1 hour. No, absolutely not. But if you do it every day, like 5-10 minutes in the morning and in the evening, it's already very good. Yeah. And then with Alexandra, you will also need to avoid disuse of muscle atrophy. And here what you can do is like mobilization. You will be able to stimulate her with toys to try to make her reach the toys with her upper limbs, with her lower limbs, and also try to initiate rolling. It's really important to, as I said, it's important to promote function and to provide exercises that will help her doing her daily life. Yeah. And then what do we need to do in the multidisciplinary care team? Yeah, is that because as physiotherapists, usually the parents are talking a lot with us. Yeah, I don't know. Sometimes I feel like a psychologist, and I because I also take the time. But parents and patients are talking a lot, and this is actually where you have many information. Yeah, because sometimes with the doctor it's a bit faster. It's not always very easy because there are many things that they need to discuss. But with us, it's then more the small talk, and also and this is where you can actually have very important information. Yeah, and so here for Alexandra, what you will need to do is to refer her to the pulmonologist. Yeah, it's really important because I don't know what, as said, from the information that I have, I can only say, I mean, what I have. So here she will really need a suction machine because she has a lot of mucus. Okay, you will need to check the cough assist parameters and suggest maybe, I think it would be necessary maybe to also use the BiPAP during the daytime. Yeah, maybe until she gets a bit stronger. But currently it's only during nighttime. And I think that it would be helpful to discuss about the fact of using it also during some periods during daytime. Yeah. Then you will, of course, need to review the first aid in acute care. Yeah, I mean, Alexandra is a quite severe phenotype, so you will need to, I mean, a severe condition right now. So it's important to know what are the things that I need to do and to provide in case of an emergency. Yeah. And of course, you can continue the current Ambu-Bag exercises for air stacking to mobilize the thorax. Yeah. Then regarding the nutritional aspects, you will need to refer her to a dietitian. Yeah, because she needs to gain weight. Okay, she also needs to stop the oral intake to avoid any more aspirations leading to pneumonia. It's really important. Yeah, and it's nice to have a close work then with the speech and language therapist, since the parents want to initiate this, because like this they will be able to work on the dysphagia and avoid any kind of aspirations. Yeah, and I mean, you know that the respiratory impairment and the weight is always linked to each other. Yeah, a patient who is losing a lot of weight instantly, let's say like this, usually it's because the patient needs more ventilatory support. Yeah, and then it's a devil circle, because when patient is losing weight, so he's becoming weaker, so even breathing becomes very complicated for him. Yeah, so this is why I think, again, it would be probably interesting to discuss about the possibility to implement the BiPAP use also during daytime. Yeah, and this will probably, with the nasogastric tube that she currently has, this will probably help her to gain much more weight. Yeah, and then the last point is that you will need to refer her to the orthopedist. Yeah, okay, she already got splints for the lower limbs. Yes, you will need to check regularly the sizes. Yeah, she will need a corset. Yeah, to try to avoid a severe scoliosis as much as possible. Yeah. Since here we are with patient, she is a non-sitter, but since she is treated, we can maybe expect the fact that she will be able to sit one day. Yeah, so you need to keep that in mind. Yeah, so this is why you need to provide exercise and discuss also with the orthopedist to improve the postural development, yeah, of Alexandra, and to improve social interactions. So I think that once she gained weight, yeah, and once she has the adapted ventilatory support, she will probably enjoy much more being in her functional chair. Yeah, it's just that right now, sitting like this for her is too complicated. It's too difficult for her. Yeah, but I think, again, it's just assumptions from what I have here. But I think that as soon as the dietitian support and the ventilatory support is adapted, she will be able to support this much better. Yeah, and then in a later stage, the standard. Yeah. The complementary techniques that you can do here are quite broad, right? It's like osteopathy, the massages for the comfort, hydrotherapy, any kind of activities that you think might be beneficial for her. But again, you will not put the complementary techniques instead of the mandatory approaches, okay? Like the conservative and proactive approach. Okay, so this is really important. Then, the second patient that I had the pleasure to meet virtually is Oscar. Yeah? And Oscar is also a patient who is considered as a non-sitter. But here I wanted also to show you Oscar because he is a teenager. Yeah? So a much older patient. So here it's a patient who was never able to sit independently. Yeah? He was never able to walk or to roll, had a very poor head control and a very limited range of motion. So here, we also expect a severe phenotype, especially because the patient is much older. Yeah, he is a teenager. Yeah? And so the current physiotherapy care plan, there is also, the parents are doing a lot as well. So here we have, it's actually the parents who are providing it. So the Oscar is not seeing a physiotherapist. So first, congratulations to the parents, because it's a lot of work to do it on your own. So here it's the parents are providing massage, magnetic therapy, phytophotochrome, paraffin. So these, for example, are techniques that I had to ask Olga what it is. Yeah, you see, this is what I said. Every country has its own ways of rehabilitation, of therapies. And so for me, it was really interesting to learn more about those approaches. Then he also goes to the swimming pool. He does some exercises with the bike and also exercises with dumbbells and exercise to strengthen the neck. Yeah. So here we see that Oscar is really, really stimulated in many, many different ways to vary his care plan, which is good. So here we got Oscar. Yeah. So in the visual examination, what we can see is that it's a patient with a general severe hypotonia again. The only movements that we can see are in the upper limbs, and they are very limited. All right. because he does have very severe contractures in the whole body, actually. Yeah, for up in the upper limbs, in the lower limbs, in the neck, in the pelvics. So we have a very severe phenotype. And then we have here, we can see here, that he also has a huge thorax deformity. Yeah, he has a severe scoliosis. So he does have a tracheostomy, but he does not have any respiratory distress. So they actually only use they only use it in case of when Oscar is sick, actually. But here we don't see really respiratory distress, as we were able to see with Alexandra, for example. And regarding the nutrition, I didn't really have this information, so I doubt that it's an oral intake that he has, so probably a nasogastric tube, or probably a PEC, sorry. So I don't know. Yeah, so the additional questions here is regarding his orthopedic management. He is using a corset with a booty support to permit, to ease the sitting position. Yeah. And regarding the ventilatory support, as I told you, he only, the daytime ventilation, it's only in case, I think if I remember correctly, it was only when he was sick, but yes, and he's only using it here during nighttime. Okay, so during the day, it's quite good. So regarding the functional assessment, yeah, since here we have an older patient, yeah, however, he's very weak and very severe contracted. So what are you going to do? Yeah, I would recommend to perform here the MFM32, because the MFM32 is a scale for, as I told you, for ambulatory and non-ambulatory patients, for a very broad range of different phenotypes. Yeah, and it comprises 3 different domains. You have the standing and transfer, the axial proximal, and the distal. And it's actually the only scale where you have everything in. Yeah, here, for example, the Hammersmith, it's only global motor function, and then the Rome, it's upper limb. Yeah, so I would use here the MFM because it would be the best suitable scale and outcome for Oscar. Yeah, you could, if you want, add the revised upper limb module to have something additional about the upper limbs. Yeah, but this is then really a question of fatigue and timing doing clinics. Yeah, sometimes after the MFM, it's already enough for the patient. Yeah, or sometimes you just don't have time to perform everything. So if you want to prioritize, I would say here the MFM, to be honest. So regarding the PT approach, so since we have here, since Oscar is a severe phenotype and older, it's important that you don't expect that Oscar will be able to work one day. He is treated, but I think that it's important that it's good that you do things that you believe are good for your child. Yeah, but strengthening or reinforcement doesn't seem to be the appropriate way for this kind of patient, like for Oscar, since he's very weak in severe contractures. So you see, for example, the strengthening with dumbbells, it's not something that I would suggest to a patient like Oscar. Yeah, because it doesn't make a lot of sense, to be honest, because you have a patient who has a severe muscle atrophy, and by providing a strengthening with dumbbells, it can be actually much more deleterious than beneficial for him. Yeah. So what's important here is to focus on the quality of life for Oscar. Yeah. So what you will do first, again, management of contractures, which means manual stretching. And here what we will do is a real focus on the neck, trunk, and upper limbs. Yeah, because this is what Oscar is currently needing for his quality of life. Yeah. Of course, you will also do the lower limbs. Yeah, but if you need to target something, then it's really upper limbs, neck, trunk, and neck and trunk. Yeah. Then regarding, you will also be able to avoid disuse of muscle atrophy by doing passive mobilization. Yeah, to do active passive mobilization in upper and lower limbs, for example, swimming, as they're doing, which is great. Yeah, you can do active stimulation of hands and fingers by trying to do puzzles or doing any kind of thing, maybe typing on the laptop. Any kind of things that will actually help Oscar to combine fun or a nice activity with rehabilitation. Yeah? Regarding the multidisciplinary care team, well, here what you will need to do is to refer Oscar to a pulmonologist, yeah, to regularly check and monitor the ventilatory support, yeah, maybe to also check when he might need the ventilatory support more during the day, yeah. So you will also need a cough assist in a suction machine, I presume. And maybe what you can try is to do the air stacking for a chest mobilization. Although I believe that Oscar's chest is already quite stiff, yeah. So again, you need to do what you think could be the best for him as well, yeah. But sometimes having a huge panel of different things, sometimes it's not the quantity of approaches that will be beneficial, but more the quality, yeah. And so then regarding orthopedic care, you will need to refer him to the orthopedist because we will definitely need regular monitoring of his trunk deformity and scoliosis. Yeah, and this is where you have actually a close collaboration with the pulmonologist to detect when the scoliosis and the trunk deformity will have an impact on his respiratory function. Yeah? So it's actually orthopedist and the pulmonologist will work together because they will both have information that will be complementary to each other, yeah, to permit the best appropriated care for Oscar. Okay, you will need, of course, to check the size of the corset, yeah, with time to time, because at one point it might be painful, yeah, and then also have a close collaboration with the dietitian because of his cervical spine scoliosis deformity, he might have dysphagia and aspirations. So just be careful regarding that. Regarding the quality of life, you can actually refer also to an occupational therapist or work together with an occupational therapist to increase his quality of life by maybe using different strategies for sitting to permit a better social interactions, or when Oscar is sleeping, for example. What could be the best way for him and what could be really increase his quality of life? The last point that I would suggest is also to refer him to a dietitian. Yeah. Again, here I'm not sure what is the current feeding approach for Oscar. So I would maybe it's a PEC. I don't know, but I doubt that Oscar is eating only by oral intake. Yeah, well, I don't know. And so you will also need a regular monitoring to control his weight. Yeah. And here again, having a close collaboration with the pulmonologist in case of at one point a huge weight loss. Yeah, because then you know, okay, we will need to adapt the ventilatory parameters and maybe also the ventilatory support time. Yeah. Regarding the complementary techniques here, it's a bit every time the same. Yeah, you can do things that are funny for Oscar, that makes him feel well. Yeah, like for example, the paraffin therapy. If Oscar enjoys this, then please continue. But if you need one day to choose between paraffin and stretching, you do stretching. You see, this is what I want to tell you. It's just at one point, it's important to understand the order of priority. Yeah. Then, yeah. The next patient that we have will be a sitter. Yeah. And here we have Carolina. And Carolina is 9 years old. Yeah. And the parents say that her condition is steadily worsening. Yeah, she's able to sit on her own, but due to the progress of the scoliosis, it becomes more and more complicated for her to sit without a corset. So here, what we expect is a quite moderate phenotype, okay, because we have a patient who is able to sit independently. Yeah. And here, the current physiotherapy care plan, I have to say, I was impressed because there is also a lot. So here we have the verticalization, yeah, daily exercises for upper and lower limbs. They're also using the Galileo vibrating platform. It's very interesting because I'm trying to start using it here, also in UK. I know in Germany they're also using it a lot, and I know with very nice results. Then they do also provide daily stretching, massage. And they also have a rehabilitation therapist with 10 sessions every 1 or 2 months. Yeah, and the parents are also doing it every day. So honestly, it's a very complete physiotherapy care plan. Regarding the visual examination. So here what we have, sorry, it's as we said, a moderate phenotype because she's able to roll, yeah, which is of course super important during the day, but also during the night. So during the night, it's avoid that the parents need to wake up, you know, that much to turn their child. Yeah, so it's important to be able to roll. Then we also see movement of the upper limbs, yeah, here, but there are still some contractors, okay. And then here we see that she's able to sit, yeah, but they still, indeed, as the parents say, the scoliosis is quite severe, so we have a huge thorax deformity. But we don't see any kind of signs of respiratory distress. Okay, so it's quite good. The additional questions that you may have for Carolina are regarding the orthopedic management. So currently she does have a functional corrective corset that she's wearing on a daily basis. She has daily splints for the ankles. She has a wrist brace for several hours and a knee splint. Okay. Regarding ventilatory support, she does have a cough assist, no, that she's using. She's using the ambu bag, yeah, to do chest wall mobilization, and she's using. She also needs the nocturnal ventilation support during illness. It was Carolina who was using the NIV during illness. My bad. Yeah. So she doesn't require it. Okay. It's only when she's sick. Yeah. So regarding the functional assessments, we have here again an older patient. She's 9 years old, but with moderate contractures and still remaining upper limb function. So what are you going to do? You will, of course, do the revised upper limb module, yeah, to understand, which is an SMA specific scale to check the function of the upper limbs. And, oh, sorry, I pushed on the wrong button. You might also do the Hammersmith functional motor scale expanded because she's not a weak phenotype. Huh? She is a more moderate phenotype. So actually here you can actually do the Hammersmith and it will make sense to do it. Huh? But since I don't have Carolina in front of me, I don't know. Huh? So I would suggest here that first I would try the Hammersmith and see if it's possible with Carolina. Yeah, because if, for example, you do the total score of the Hammersmith is 66 points. If you have 3 or 4 points out of 66, honestly, it makes no sense to use the Hammersmith. Then you will use the MFM. Yeah, but if you see that you have more than 10 points on the Hammersmith, well, then it's worth to use the Hammersmith and the roll. Okay. So you see, it's just to show you the rationale that, for example, I have when I have a patient in front of me. So regarding the physiotherapy care approach, so first of all, surprise, surprise, management of contractures. Yeah, you will definitely need to continue stretching the upper and lower limb. And here also the trunk. Yeah, because Carolina is a sitter. She does have a severe scoliosis. Yeah, so at one point you will need to prepare her for an arthrodesis, a spinal fusion. Yeah, so you will need to stretch her trunk, you know, as best as possible to prepare it for it. Yeah, and of course, then also the neck. Then regarding disuse of muscle atrophy, you will be able to provide submaximal aerobic exercises like a postural stimulation, I would suggest, with a Bobat ball. Yeah, or for example, the Galileo that she's doing. Yeah, the active assisted mobilizations, like for example, also swimming. Yeah, she can do some bike or fine motricity exercises like painting or playing. And it's still important to stimulate transition. Yeah, because she's still able to roll. Yeah. Not on her belly, not in prone, yeah, but at least from one side to another. Yeah, so it's important to continue to stimulate that, yeah, to keep that as long as possible. Regarding the multidisciplinary care approach, here regarding respiratory care, you will need still to refer her to the pulmonologist to monitor regularly the cough assist, check also if she needs a suction machine at one day, and monitor when the nocturnal ventilatory support will be needed. Yeah, I mean, currently she doesn't need it. She only uses it during illness. Yeah, but it's important that you monitor this to anticipate and to see, okay, we see that her forced vital capacity is starting now to drop. And so we will need to check this carefully. Okay, so when Carolina at one point complains with symptoms like headache in the morning, when you see again a loss of weight, or when she's really tired during the day, then you will maybe need to check, is it not the case that she needed, or that she already needs it now? You know, so it's just, I always think it's always important to try to see signs before, to anticipate things, and to be prepared. It's always easier to do action when you anticipated and prepared everything instead of like discovering everything. So then we have the orthopedic care. You will need to refer, Carolina, also to the orthopedist. I mean, ideally, the patients like Carolina would have actually growing rods in younger age, to permit actually a better development of the spine. But here, what you will need to do is to increase your independence by using an electric wheelchair, which is adapted. So also check the sizes. You want to promote the social interactions for her. So you want also to check the sizes of her splints for the wrist and the knees and the brace, and of course continue the verticalization that you can do in collaboration with the physiotherapist. And regarding the nutritional care, you will need to refer to the dietitian to monitor closely also her weight. Because here we see that Carolina is not, she's not in underweight. But you know, with phenotypes with Carolina, if at one point they have too much weight, this can actually increase the hypomobility. But otherwise, so it can actually make moving much more complicated. I'm not saying that she needs a diet. I'm just saying that you just need to be careful regarding that. Just monitor it. And then at one point, if you have, as I said, a huge weight loss, then you see that you can think that this could be due to a respiratory impairment, and maybe the implementation of ventilatory support could be then a good thing. And then, as I said, the complementary techniques here, it's are maybe it's a bit bigger. The range of complementary techniques is a bit bigger because she is able to sit. So you can do like any kind of type of activity or sport or hobby that she really enjoys. And then the last patient that we will have today is a walker, and it's Platon. And here we have Platon is 11 years old. So here he's able to walk independently, to sit independently, but he needs his upper limb support to stand up from a sitting position. Regarding his physiotherapy care plan, he does have regular stretchings of the Achilles tendons. On a simulator, there is a video attached, and then also does have daily training. So exercise for the upper and lower limbs. He also goes to the swimming pool 3 times per week, which is really great. It's really nice that you have this opportunity, and he's doing a lot of cycling. So here again, we do have a very complete physiotherapy care plan. So regarding the clinical assessments, so I will just, I know that I have here the sound that I will need to take away. Sorry. Okay. There's one video where there's sound and I don't know which one it is. So I'm sorry. So here what we see, it's a stronger phenotype. He doesn't really have contractures. He has no thorax deformity. He maybe has a slight scoliosis. But we see, usually when we say, okay, he is a walker, we don't need to concentrate and to focus on the upper limbs. And this is a major error. It's not because a patient is a walker that we will just need to focus on the lower limbs to keep him walking as much as possible. No, you also need to check actually the upper limbs. And here we can see that we do have actually, we do have some weakness in the shoulders also. You see, he needs compensations to bring both arms up above the head. Of course, since he has worked, we also see a weakness in the hips, in the quadriceps. His knee extension is very difficult, that we can see here. You see, here we can see he's compensating, when he works. So, which is normal. Huh? So he has a weakness in hips and in quadriceps and some difficulties to raise his feet. So this is why he always need to work a bit, on the side like this. And maybe here I would say he is maybe a bit slightly overweight, but it's quite common in walkers, to be honest. So the additional questions that you can ask here is to check first his current orthopedic management. So here he does have ankle splints during the night. Yeah. And indeed, yeah, he does have a scoliosis. Yeah. So regarding the ventilatory support, he doesn't need any right now. And additional information that might be helpful is that the most difficult thing for Platon is that it's the extensors on the legs that are not really working. I mean, I'm using the words of the parents. He cannot climb stairs or stand up without support and cannot squat at all. Yeah, well, it is a patient with an SMA type 3. Yeah. So what are the functional assessments here for Platon? We do still have an older patient, but he is a walker, but already presents a weakness in upper limbs. So we will do the 6-minute walk test, definitely. Yeah, we want to see what is the maximum distance that he can walk within 6 minutes. Yeah. We will also do the Hammersmith Function Motor Scale expanded because we do have a more stronger phenotype here. But we will also do the revised upper limb model to check the function of his upper limbs. Yeah, this is really important. Yeah, because this will help you also to target and to orient the care plan. You see, this is why I told you it's important to have those kinds of assessments, not only to check if a drug is working or not, yeah, but also to orient the care plan. Yeah. So here regarding the physiotherapy, you will need to manage the contractures and the range of motion, even for Platon. Yeah, so he doesn't really have contractures yet. I mean, from what I was able to see, but I would suggest to do active, assistive, and passive stretching, as he's doing on this simulator here. It's very good. Yeah. So now we target the lower limbs and the back. Yeah. So it's important also to do exercises like for the lower back, as we can see here. Yeah, because Platon is slightly is a bit overweight, so it might be a bit painful in the lumbar region. Yeah, so you will need to stretch that, and even if the contractures are not visible yet, you can already start to work on it. Yeah, so this is really important. Regarding the functional improvement here, well, you will be able to do submaximal exercises with Platon, like swimming, like doing with the Bobat ball, for postural postural stimulation. Yeah, you can have exercises targeting the upper limbs. You can still continue to stimulate transitions, especially since for Platon it's complicated to stand up from a sitting position. So you can still continue working on that. Yeah. And regarding the multidisciplinary care team, well, first of all, respiratory care, you will tell me, yeah, but he doesn't have any ventilatory support now. Yeah, that's right. But you will still need to refer him to the pulmonologist to provide a yearly monitoring of the respiratory capacity to detect when will be the moment when he will need an IV and cough assist. Okay, this is really important. Yeah, you cannot do it. I mean, it's, as I said, it's better always to anticipate than to do it once it's a bit too late. Yeah, and then you will also need to refer him to the orthopedist. Yeah, here, I mean, even for walkers, there is the possibility to use a thoracic brace only for the sitting position. Yeah, to slow down the progression of the scoliosis. Yeah, and sometimes, but of course not for walking then. It's just sometimes for sitting, when you know that Platon will sit a long time, it can be helpful to maybe have a kind of brace, that have, not this kind of very, fixed brace, something like this, but it's more like a brace that helps him to be supported actually. Yeah, and then maybe for long distances, you can also provide a wheelchair. Yeah, even if he's ambulant. Yeah, because we have SMA is linked with a huge degree of fatigability. So you want to keep him well. It makes no sense that he works in the morning so much that in the afternoon he cannot work anymore. Yeah, it's always good to find a good balance. I mean, Platon is also older, so he knows him very well. He knows exactly when he will need support and when not. Yeah, and then the last point is that you will also need to refer him to a dietitian, because you will need to monitor the weight carefully. Yeah, because overweight, as I said also for Carolina, overweight increases the difficulty of moving and walking, and for example, also standing up from chair. Yeah, so this is just what's really important to keep in mind. Yeah, and then the complementary techniques, again, any type of activity or sport or hobby that Platon might enjoy. Yeah, always be creative. Find something that will actually combine exercises that will promote function and that Platon also enjoys. Yeah. Then after those cases, there were two other points that I wanted to discuss with you, and I receive frequently questions, yeah, and colleagues in other sites in Italy or in Belgium or France also receive those questions, and usually it's a bit complicated. Yeah, patients coming from other countries do have their own way of treating patients, and so usually they're asking, can we do Bobat and Voishta with patients with SMA? Yeah. My problem is here that Voishta and Bobat are rehabilitation techniques for patients impaired with a central nervous system disease, yeah, which includes, for example, spasticity. So the whole system of those therapies is based on spasticity. So patients with SMA do not have spasticity; they do have stiffness. Yeah, I mean they do have contractures. Yeah, so it's two different diseases. Yeah. It's, for me, it would be like you're doing bakery, and instead of using sugar, you're using salt. Yeah, it looks exactly the same, but the taste will be totally different. Yeah, and here it's the same. Yeah, it looks like it's for a neurologic rehabilitation, but in neurology, it's two different types of diseases. Yeah, with two different mechanism of actions. Yeah, the only thing is that I can say is that maybe some aspects may be used if you think that it could be helpful. But basing the whole rehabilitation on those kinds of therapy approaches, I don't personally think that it's the right way to proceed. Yeah. And then we also receive a lot of questions regarding TENS and electrostimulation. In literature, there are pros and cons. Yeah, so it's complicated to say. Yeah, it's like, is it important to stretch before or after a sport activity? We also have pros and cons. The thing is that in consensus with other colleagues, for me, is the idea with patients with SMA is to provide them a rehabilitation care program that promotes a global approach. You remember, that promotes function. Yeah. And so using, for example, electrostimulation on one muscle, is it really beneficial for the patient? I'm not convinced, but voilà, it's my personal experience. Yeah. And then the last point I want to check with you is that I know that sometimes as parents, you want to provide the best care for your patient, for your child, right? You want to do everything as best as possible. And sometimes in some countries, it's the parents need to face and to do other rehabilitation. For example, I have this here in UK. In UK, the physiotherapist, I mean, patients with SMA don't really see the physiotherapist very often. So I was really shocked when I arrived here. I was like, oh, it's totally different compared to what I'm used in Belgium, where I grew up, or in France, or in Germany, for instance. So, and so parents need to do everything on their own. Yeah. And it's sometimes complicated to see the limit. Yeah. When is it enough? Yeah. So this is, again, it's important to sometimes to try to focus on the quality instead of the quantity. But as parents, when you don't know, yeah, you just try to do the whole panel of what's available and what's possible. And it's complicated to see, okay, what should I prioritize? Yeah. So I think at one point, it's important to keep in mind that the rehabilitation and, for example, stretchings, like really the mandatory things, the keys is like stretching, it must be on a daily basis, like brushing teeth. Yeah, you don't brush your teeth once per week. No, you do it every day, twice per day. Yeah, so it must be the same with the mandatory approach. Yeah, like the stretching, as I said. Yeah, but on the other side, since it's patients with SMA, they do have a lifetime disease. So you will need to balance what is really necessary and what's maybe not. Yeah. Okay, my son is really enjoying this, but we already have so many things to do. Is it really necessary? You know, at one point, there are also children. Yeah, if, for example, for the younger patients, there are children. They also need to have a child life, okay, and to live their childhood. Yeah, you cannot have one day with many different rehabilitation things to do, etc. No, at one point you need to find the best balance. Yeah, and this is again, it's possible once you have a multidisciplinary care team, because you have all the important intervenants there who can then adapt and orient the care plan and also prioritize the things for your patient, for your child. Yeah. So thank you very much, and that's it. Spasiba большое. Again, I'm so sad that you cannot hear my great accent in Russian, but I hope you enjoyed it, and I'm very happy to reply to questions.